And I think let's continue to discuss and have some conversation on how we could integrate the discussion of pleasure in our own practice, in our sexual health services, and in our campaigns. Rayner and Ben will join us in our panel discussion, but I will be calling two other panelists for this discussion, Dr. Iskandar Azwa and Dr. Angela Kelly-Hanku. Dr. Iskandar Azwa is an associate professor of infectious diseases at the University of Malaya, Kuala Lumpur, and he is also the clinical lead for the HIV service in the infectious disease unit at the University of Malaya Medical Center. Welcome, Dr. Iskandar. And I also would like to call Dr. Angela Kelly-Hanku. She is an interdisciplinary researcher and the deputy head of the Asia and the Pacific Health Program and lead of the Global Health Equity and Justice Research Group at the Kirby Institute and co-joint senior principal research fellow at the Papua New Guinea Institute of Medical Research. Welcome, Dr. Angela. So I think let's begin our conversation on how we could really integrate pleasure in our sexual health services, and how does it really contribute in reducing stigma in our, in our practice?
Yes, and thank you, Iskandar and Angela, for joining us on this panel. I feel that after hearing both of the talks here, I feel that we probably can be more tangible about what we can do here. I mean, prior to hearing the talks, I was like, I know we must do something, but I really don't see what could be like an immediate actions that we can take, or what can be something that many of you here, or many of us here, have already been doing, but have not shared it with others, or have not thought of it in a way that, oh, this is what actually I'm integrating pleasure into my policy advocacy, my research practice, my service, clinical services, or even my educational or promotional health campaigns, right? So here, I just would like to use this opportunity for each of you to kind of like think through that possibilities, potentials, no? And then please share with us what you have been doing, or what you are thinking of ways that we can do this together. So maybe can I start with Dr. Iskandar, because you are coming from Malaysia. I don't know what we can say about like stigma around sex, around sexual pleasure, around chemsex, substance use in the country, which probably has affected how you have been doing your research advocacy, clinical service work, and what will be your suggestion?
So thank you, Nittaya. I've had some experience with this, with the IS Manila conference in March, and where sexual pleasure was a big theme also of the meeting. And we were asked to discuss this, so I've had some practice around this. Now, I think it can be divided more or less into three areas. First of all, maybe a perspective as a clinician, and my background and my team's background in general. Number two, in the context of, yes, a predominantly Islamic country, and I'm the only Muslim person on this panel, and of course the challenges associated with talking about sex openly in a country which tries to suppress you to a large extent when you talk about it. But having said that, given the platform, even in a country where they don't necessarily feel comfortable about talking about sex, if you give them the right platform, they want to talk about sex. And that's at every level, from teenagers to your clinical setting and women seeking sexual and reproductive health. And also from a policy level. And of course, the issue around chemsex driving new HIV infections within the region, you can't get away talking about sex. So maybe just from a personal perspective and a clinician perspective, I think it's not just in Malaysia, but in the settings we have, a lot of infectious disease physicians may not have and we've talked about this a couple of times, the adequate sexual health training. So they're not asking the right questions, even in the clinical setting. So I think, very conservatively, we probably should start at better sexual health training in infectious disease physicians. So at least they're asking the questions. And I use it as an example. I spent some time in the UK, and then when I came back and we were doing clinics in KL, you know, a sexual history was never ever really discussed, you know, in the beginning, when I came back as such, and I found that very odd. So I think that needs to be emphasized, important sexual history taking. So we're really going back to the basics. I mean, you presented very nicely what we can do, but I think it all also depends on context and the experience of people encountering people living with HIV. I think U and U equals to U, you can always start with the communication around U equals to U, and that provides the ideal opportunity for talking about sex. Because if you're not talking about sex, when you're talking about U equals to U, well, you're not talking about sex, full stop. And also the situation around PrEP, if you're not bringing up PrEP, you're not really talking about sex. And once again, if you're not talking about sex and you don't feel comfortable about talking about sex, then you should really refer to somebody who can talk about sex, or at least get trained. So that's the second issue, and that's something that I think our team feel generally very strongly about. The second issue is context, of course. I think following the public health approach is probably the best, and we get away with doing a lot of things when we start transitioning from just taking a sexual history to talking about sexual relationships and moving from a disease-centered focus to a more person-centered focus. And we've been using these terms again and again, person-centered focus, and what does that really mean when it comes to sexual health? So essentially moving on to away from the absence or presence of disease or infection, which has always been our traditional focus, but to something more around sexual relationships, healthy sexual relationships, and pleasure. You know, and I give you an example. A PhD student in one of the neighboring universities approached me with a PhD proposal of wanting to look at sexual pleasure and serodiscordant or serodifferent relationships. It was a different university, and he was, and what he wanted to do basically was look at sexual pleasure, but he was not allowed to. And that's the setting, unfortunately, that we live in. But he was allowed to talk about or look into sexual satisfaction, which, you know, I think it tones down and prevents people, and once again, is a clear example of stigma. So, I mean, maybe I can just start with that. At a policy level, I think it's very difficult to incorporate sexual pleasure unless you've gone through those initial stages of at least providing the environment where people can talk about sex a bit more. And it may be easier to focus, as I said, on talking about sexual relationships, absence, presence of disease, rather than going into sexual pleasure. But ultimately, it is, for people living with HIV, it's a very important thing, and it gives them the platform to go on and talk more about sex. But very hard, certainly from a policy level, unless you incorporate chemsex into the story and conversation.
Yeah, thank you. Yeah, but I feel that this kind of like demonstrated to us that even in a setting where you think that it's probably safer for you not to talk about this, you can like end your career without talking about sexual pleasure. Yeah, but we cannot end HIV, STI, and viral hepatitis for sure. But we can still kind of like doing this in a way that is like tailored to the context. No? Yeah. So sometimes, like when you're saying about like downplaying or hiding sexual pleasure when you do, I mean, this is what we usually do automatically without like thinking clearly about that. We may have to do that as an introduction of talking about this issue, and then be more and more provocative, instead of like doing this in a provocative way at the beginning. I'm not really sure if anyone would like to share anything about this, and I know, Angela, you probably have thought through this in a context where like gender-based violence is something that is that is the issue of the country. And now you're talking about sexual pleasure. How can you really like integrate this together?
That's a great question, and that's exactly what I was thinking, is that, you know, from a clinical point, I have to confess I'm not a clinician, but, you know, at the moment we're still trying to get all of our sexual and reproductive health clinics to screen women and other people for GBV, because in some parts of the country up to 50% of cisgender women will have experienced sexual violence in their life. And so for us, the idea of pleasure, forget about it from a clinical screening point of view, but people don't talk about it in their own personal lives. Clinicians don't even talk about it in their own lives or think about it. Asham led a training course for clinicians maybe 6 years ago that I was asked to come and present and talk about pleasure. The clinicians were not ready to think about pleasure in their own lives. And I think if people can't think about pleasure in their own lives, you're not going to be able to think about pleasure in someone else's life. And in a country where, you know, conversely, Islam is very important in Malaysia, Christianity and increasingly conservative Christianity in countries like Papua New Guinea equally frame. And so we have this cultural war going on around sex, and similarly in Indonesia with the new laws where premarital sex is illegal. I mean, we have this bigger, wider cultural law. So I think why Nittaya, I understand the need for activism, but I think this pleasure project is a longer term game. Yep. And I think if we released everything so fast and with fury, I think we would lose. And so I do think it is okay to talk about safe, meaningful sexual relationships. And that is the absence of violence, being able to consent when and with whom you have sex. What type of sex you have. I mean, I think, you know, I think Ben was on it last year at IAS. We had a forum on heterosexual anal intercourse. It was fabulous. Like, where are we having those kinds of conversations as well? And I know in Asia and the Pacific, much of our epidemic is focused on gay men and other men who have sex with men and trans women and people who inject drugs. But we also need to be including issues about heteronormativity and pleasure in those relationships as well, and the number of women with HIV and to have pleasurable and meaningful relationships. That's not just about having a baby born without HIV. And, you know, I'm just reminded, having Phanuphak and Natalie and our colleagues from Thailand, one of the things that we still as a community have to address is perinatally acquired children who are becoming young adults. For them to enter into a sexual life, sexual debut, where they know that they have a right to pleasure and to be able to safely disclose their HIV status. And it takes me back to the old days of Australia with the children with haemophilia becoming young adults, where they were living with a sexually transmitted infection and yet hadn't been sexually active yet. And we even see that, to be honest, in Fiji, with some of the young children as young as 12 being infected by injecting drug use. They're not even sexually active yet. So I think having conversations about those younger children who are coming up into adulthood, that they have a right to pleasure, is also really important.
Yeah. Anyone would like to add to that, like Ben, Rayner?
Well, I guess I would just say, one of the first things you posed, Nittaya, was how can we use sexual pleasure to help defeat stigma? And I don't know that that's actually the right way to think about it, because pleasure itself is so stigmatized.
Yep.
I don't know that we're going to be able to use this concept of sexual pleasure to help defeat other types of stigma. I think what we need to understand is all these stigmas are really coming from the same stuff. And we have to then just try to find ways to bring these more positive elements of sex and sexuality into our work, often below the radar, under the radar. I think it has to be, because if you do it too openly and too proudly and too outly, then it's just going to bring people down on you. It's going to make it actually harder to defeat stigma. So I think the difference is, when your comments before, Nittaya, I think the difference is knowing when we're just doing things unconsciously, that we're even self-censoring ourselves from talking about pleasure and the positive aspects of sex when we talk, versus doing it tactically, when you know that you're phrasing things in a particular way to protect yourself and the work you're doing, but deep down you know what you really want to get done, which is to try to make things a bit more positive and really talk to clients in a way that's going to be meaningful for them. And knowing the difference between those two.
Yeah, and I mean, all this together bring me to think more seriously about investment in I don't want to use the word training because it's not training. Like Angela, when you told us the story that like you're talking about pleasure, but people are not ready to hear about others' pleasure because they don't even think about their own pleasure in our own setting like this. I don't know if I even think into myself and really think about sexual pleasure in my life and whether that's like if I feel in that the pleasure meter that when you show, whether I will have like 1 here or 10 there. I think like we probably will need to like think of a strategy for us as a provider to be able to really think about sexual pleasure and link it into ourselves first. If we still have stigma of our own sexual pleasure, then we probably will have to get over that before we can think about that for other people.
I just wanted to add, and this is some of the findings, in fact, from the U=U Thai campaign, and something that you mentioned last night, in terms of efficient communication of what matters most to people living with HIV. And it's once again making it a humanized approach and getting narratives of people living with HIV. So what matters to them? And ultimately, and I think given the space and platform, sexual pleasure will come out of it. And it's an important aspect given the right platform, whether it's people living with HIV or people who are HIV negative. And using those narratives from a human approach, and in addition to a more decentralized or demystified approach. I think it's one way you can get it out in terms of public health campaigns or efficiently communicating sexual pleasure.
Yeah, can I just add on to that around the value of having positive voices? We've just finished a 3-year longitudinal qualitative piece looking at serodiscordant couples in Papua New Guinea. And whilst pleasure was not something, it's certainly not something that's spoken about in PNG in that way. Christianity is very entrenched. 50% of all health services, including HIV, are provided by a Catholic system. Even where they're not provided by Catholic systems, you're usually Catholic or Anglican or Protestant in a government facility. But what people found, and this is without a context of U=U, because we don't have that culture yet in Papua New Guinea, and I think we have to realise that that is not the story across our region. We are really diverse and we don't have the viral load roll out across the region equitably yet. We don't have a history of understanding even what U=U. But people talked about being normal. And they talked about because they're on treatment, they could just live a normal life. It wasn't flash, it wasn't spectacular, it wasn't pleasure, but they were just living a normal life like everybody else in their community. And that in itself was incredibly valuable. And that destigmatises HIV. And I guess it depends what we're trying to destigmatise, HIV in our community or pleasure. Pleasure is a larger, bigger thing for everybody, and HIV is something much more specific. But at least in these communities where people were seeing they could live well, they didn't have access to viral load testing at that time. Many of them were having children who were HIV negative, and they could just live a normal life like the rest of their friends. And I think that, to me, is a way to approach.
Agreed, yeah.
Yeah, destigmatising.
So I think it's because I haven't had coffee. My thoughts kept on it keeps on going back and forth. So I'm trying to make it more concrete right now. So I don't know, the issue of stigma. I really like what you said, Angela, because it really depends on what we are destigmatizing, and I think it's just so complex. But one thing that was swimming in my head that I'm catching on now is that I think Nittaya, you were talking about what can we do, right? And I think I just feel that, okay, when we look at, who is currently working on more pleasure-based approaches, who is doing it the best? The community is actually doing it really well, and people are doing it really well already. Who needs to catch up? I think as researchers, as you pointed out, right, we need to catch up. I think healthcare providers also need to catch up, or maybe like meet people where they're at. I wouldn't say catch up because I know everyone has a lot of things to do already on their plates, right? But I think we need to maybe at the very least have we have trauma-informed care. Trauma-informed care acknowledges trauma. It also uses that as a lens of a point of entry. I think pleasure-informed care is the very least that we should do, which is to acknowledge that pleasure is a very meaningful concept when it comes to, like sexual health, and to also use that as an entry point in terms of how we measure and operationalize things. Because this thing, sorry, I want to hop on this point of like PrEP again, because I just couldn't get it out of my head yesterday. I think, and actually, interestingly, Ben and I have been talking about, adherence effectiveness, which is this idea that, when you measure PrEP adherence, you should measure it in the context of sex, or, when people are at risk. It's very meaningless to actually measure whether someone is on PrEP like 12 months or like 6 months, or someone stopped PrEP, or it's a bad thing. Actually, it's not. If someone doesn't need PrEP at that time, it's actually a great thing that they have managed to be empowered themselves to make the decision for themselves not to use PrEP. So, but then as public health professionals, are we fixating on the fact that we cannot trust people to be empowered themselves? And I think it also relates to this idea of pleasure-informed kind of care, right? So are we able to understand that people can use pleasure meaningfully, and to actually have sex and use things like PrEP in a pleasure-based approach without us seeing it as a problem? So I think that's like the next step.
I think what's interesting in this panel discussion is as we create our answers, we produce more questions. how to really introduce it to our own setting, our own practice, given our different cultural contexts and our backgrounds. And I think it's about time the people in this room to join us in our conversation if you have any questions that you would want to ask. But I think I'll ask some of the questions that were asked in the virtual panel. First question will be for Ben. It made me reflect on my own research, and I'm wondering where you have found some examples in which researchers and health practitioners can initiate conversations about pleasure when the clients or patients already feel reluctant to talk about it due to existing power dynamics.
Yeah, definitely. So I can't think of specifically whether I sort of came across that, but I'm sure it's there. I think in a lot of the resources that are there, I'm sure this is talked about. I think in those one-on-one encounters, I think a lot of it comes down to rapport. It's just that simple stuff that Iskandar was saying was before about person-centered care. I don't think you can jump in with a client who clearly is not ready to talk about this stuff, and the same as what you said, Angela, about P&G. Just jump in there and start talking about something they're not ready to be talking about. But I think you can talk about these kinds of concepts in a pretty non-threatening way, and then use a point of entry to see if the conversation goes further. You can ask, are you happy? That's not a very scary question for a clinician to ask someone, right? Are you happy in your relationships? That can lead into more questions about, well, what parts of your relationships are you happy about or are you unhappy about? How does sex fit into that? You can build rapport over time in a way that can actually be quite non-threatening and doesn't have to launch into using terms like sexual pleasure. And like what you said before, Iskandar, about there are other terms like sexual satisfaction or various ways we can kind of dress this up to make people feel more comfortable. So Budi, while I can't say that I specifically can't speak to specific research, I know it is in there and I know it's there in some of the resources. So I really do encourage everybody to look at that Global Advisory Board website. It's just got so much on there and it's really, really interesting and really, really useful.
Thank you. And we also have a question for Rayner. How can we promote voluntary harm reduction model in conservative countries? And what can we healthcare providers do to provide friendly environment for substance users to retain?
That's a great question. I often ask that myself. And I think, what I learned that countries have done, and I think these are some best practices, is that there are laws, there are punitive laws in many different countries, who have been innovating in these contexts. Communities have been innovating. Communities have been helping themselves when no one else will help them. I think that there are many community-based harm reduction approaches. When you have, I think this is the tough part, right? I think different contexts, there's no one solution. In different contexts, you have different relationships with the police. you have different relationships with hospitals. I think it's really getting stakeholders together to really understanding how, in spite of these laws, which are political sometimes, we can still have health-based and evidence-based approaches in spite of political interests. So, thinking about how, you can have conversations with the police to have, pathways to care, or, have certain hospitals that, would say that, we won't report people who come here. Actually building those networks are really important. And, if we don't have top-down harm reduction services, we cannot wait. We have to look at it from a bottom-up harm reduction services.
Is there any, we are coming to the end of the session now. I'm sorry that I probably couldn't manage the time very well. But is there any burning question that you would like to ask any of us here on the panel? If, yes, it's. Okay, so 2 questions. Bruce, yeah?
Yeah, hi, Bruce Eggins from UCSF. Yeah, I'm just wondering, for those of you that work in the medical profession, whether you've been able to make any inroads or had any successes in navigating professional schools and education of physicians in the work that you do. I think we all know it's a huge challenge, both on the in-service and the pre-service side. So just wondering if there's any examples that we might draw from. Thank you.
Specifically around sexual pleasure? No, not yet. not specifically around sexual pleasure. No, not as yet. I think we've got a way to go before that. As I said, I think the path less traveled and probably safer path, particularly in the setting that we're at, is maybe to go around prevention of transmission and serodiscordant, serodifferent relationships, intimacy, and strength of relationships. And mental health and the effect on mental health, with knowing that pleasure is a bit difficult currently.
For the final question.
Yeah. Hi, good morning. I'm Rod from the Philippines, and wonderful talk. I'm just curious about the one of the discussions earlier about how hesitant the healthcare providers are, like nurses or medical doctors, in asking the right questions. So my question pertaining to that is that, has there been, communication approaches, or should I say, it's not really a capacity building, it's more like desensitization training that has been going on and available as an evidence for programs manager to use in implementing programs to desensitize medical doctors or nurses in terms of being open to talk about sexual pleasure in the clinical practice or patient interaction?
Yeah, I think there are, but I think they're probably quite small programs, they're probably quite niche, and they probably exist only in Western countries. Yeah. That's how I'd summarize it from my reading. But I think there is some stuff in the literature about doing these kinds of really positive training courses that you can do with clinicians and other kinds of providers that can really open up their minds. And if you go again and look at that website that I mentioned, it really, when you look at the training slides, it really takes it through in quite a non-threatening way, a really desensitizing kind of way to get people to think about their own lives, think about their clients in a positive way. But of course, again, it's hard to scale something like this up. If the funders and the policymakers don't think this is the most important priority, that's always going to be a challenge.
Understood. So maybe it's a good pickup point to start thinking about certain programs that might be applied in Asia Pacific, right? Thank you.
Thank you. Unfortunately, we don't have the time. We're already over time, as you guys could see in this iPad. But thank you for the panelists for joining in this wonderful discussion about sexual pleasure. And I hope we could continue to discuss more as we go along with our sessions today, tomorrow, and the next few days. So thank you, everyone, for asking your questions. And I just want to remind all attendees to complete an online survey, which will be sent to your email at the end of this day. And we'll have a coffee break outside the meeting room, and we will proceed with our second session, Reducing Stigma through Patient-Centered Tech Solutions, by 10:50 a.m. So with that, good morning, and we'll see you later.